Okay, good afternoon, everyone. Welcome to the Addiction Health Services Research first monthly conference of 2021. This is a virtual workshop today as part of our monthly workshop series. For those of you who are new to the AHSR community, we're delighted to have you and thank you for joining us today. And if you're an AHSR regular, we welcome you back for our continued programming. The Addiction Health Services Research Conference is typically an annual conference that brings together researchers, clinicians, policymakers, and funders to discuss the latest cutting-edge addiction health services research. And this year, it's been an ongoing workshop series as well as a main event because of the differences in programming related to the COVID pandemic. Today, we're delighted to be bringing you some expert speakers, and I wanted to highlight before we introduce the speakers that all of the programming to date, as well as the programming you will attend today, is available publicly on the AHSR website, which you can find at ahsrconference.org. On the screen in front of you is the homepage, and there are links to all of the activities that were presented during the main AHSR conference activities in October, as well as every single abstract that was presented at the conference has now been published in the journal Addiction Science and Clinical Practice. Everything's also viewable. There are edited workshops available on the conference homepage. You can also link to the AHSR brochure, which can be found at ahsrconference.org/schedule, and that has hyperlinks to every single presentation that happened back in October. So we encourage you to check that out. After today's conference activity will be added to the ahsrconference.org/monthly workshops page. The last two that we've had back in November and December are already available for your viewing, so you can go to that website and view our prior workshops as well. We'd like to give a big thank you of appreciation to the New England Addiction Technology Transfer Center, which is our lead coordinator and sponsor for these workshops. If you have not heard of the ATTC network, I highly encourage you to look at the map on your screen and to reach out to the ATTC in your region. It is a SAMHSA-funded network that helps to bridge the gap between research and practice and provides training and technical assistance to the workforce to really help them to adapt and implement evidence-based interventions in substance use treatment. I'd also like to thank the AHSR Planning Committee. We could not have done this without the full New England ATTC team and the Brown University School of Public Health administrative staff. Also, we were led by a big committee of individuals across universities, and I'd like to highlight those in red were some of the key members based at Brown that really did a lot of the heavy lifting this year. I'd also like to thank Randy Brown, Bree Deo, and Andy Quanbeck from University of Wisconsin-Madison because they had a NIDA R13 grant that provided additional funding support for these activities. So throughout today, today is a Zoom meeting, which means that at any time you can unmute yourself or turn on your video. We encourage you to please keep yourself on mute when you're not speaking. There will be breaks in today's presentation that are planned for us to accept questions. At that point, you are welcome to turn on your video if you'd like to actually ask your question verbally. Otherwise, we encourage you to use the chat freely. So please feel free to put a question in the chat at any time, and we will hold those questions for the planned breaks in between our speakers. So in a moment, I'm going to turn it over to today's presenters. We are delighted to be joined by a power team from Cherish, which is the Center for Health Economics of Treatment Interventions for Substance Use Disorder, HCV, and HIV. They have been long-term partners at AHSR and have frequently led very popular methods workshops, so we're delighted to have them here today. They'll be talking to us about conducting economic evaluations alongside substance use disorder clinical trials, statistical methods, and best practices. And we have Drs. Jalali, McAllister, and Murphy that will be leading us in our discussion today. So I'm going to turn it over to them. And I believe we'll be starting with Dr. McAllister.
Yes, hi everyone. Thank you so much for joining us. I'm just going to get ready to launch the slides here. Hopefully you can all see this. Yes, and thank you, Sarah, for that nice introduction and for saying the whole Cherish name so that I don't, do the tongue twister trying to get it all out. Sarah has provided the title for our talk today, and so we're really going to be getting into more of the methods and statistical methods, statistical considerations for cost effectiveness analysis. But I'll begin with a brief introduction. I'm Catherine McAllister from the University of Miami. I'm in the Department of Public Health Sciences in the Miller School of Medicine. And I'm joined, as Sarah already informed you, by Sean Murphy, Dr. Murphy, who's at Weill Cornell Medical College. We are respectively the director and co-director of the methodology core of Cherish. And the third presenter is Dr. Ali Jalali, who's also at Weill Cornell Medicine. We do not have any conflicts of interest to declare. And so I'm just going to jump right in with more of an introduction. And for those of you that are not familiar with Cherish, the mission is to, as it says here, develop and disseminate health economic research on healthcare utilization, health outcomes, and health-related behaviors that informs substance use disorder treatment policy and HCV and HIV care of people who use substances. So it's a meaty mission statement, but we've been doing a lot of great work over the past 5 years, and Cherish as a P30 center was renewed this past summer. And so we're really excited to be able to continue our work going forward for another 5 years. And we are under the stewardship of Dr. Bruce Shackman, who's also at Weill Cornell. But this is a multi-institutional center. So we have Miami, University of Pennsylvania, and Boston University, Boston Medical Center also involved. So it's a really nice team to work with. Just want to give a shout out to some of our resources. So you've signed up for this workshop on, the statistical considerations of cost effectiveness analysis. And if you don't know much about that area of work, we do have resources through Cherish that can help you. We have instruments, we have a panel, an affiliation of experts that can help with manuscripts and grants. And so this just gives you some examples of our resources, and there's the website there. You can check things out in more detail. I won't take up too much time going through this, but I also need to give a shout out to the non-pecuniary, the non-compensated consultation service. Sean Murphy is the director. And this has been one of our main initiatives as part of the methodology core in Cherish, which is to try to increase interest in doing health economic research, whether standalone proposals or papers, or adding an economic analysis component to research. So we have a lot of ways of helping with that with the goal, and feel free to contact us for more information. So briefly, the plan today is I'll do just a brief introduction, hopefully brief, and you can learn more about this area. We have modules in addition to those resources I just showed you. We have recorded modules on various aspects of economic evaluation that you can find at the link there. I'll wrap up my introduction and then pass the baton to Dr. Murphy, who will talk about methodological considerations in cost effectiveness analysis. And we will end up with Dr. Jalali talking about working through some applied examples using data. The objectives are understand about how economic evaluation serves as an important complement to clinical trial research. Learn about the methodological issues, defining things like defining analytic perspective, valuing outcomes, addressing sampling variability and missing data, and calculating cost effectiveness ratios. And then attain some basic knowledge on how to execute statistical methods recommended in cost effectiveness analysis of clinical trial data. So we hope to be able to achieve all of those today. So I'll just begin by motivating our interest in economic evaluation. You've signed up for this workshop, so hopefully I don't have to justify why economic evaluation is important too much, but it really comes back to the fact that we have to decide how to allocate scarce resources. We can't fund everything we would hope to do, so how do we decide what to support? So there's this very key focus on decision making and how to create evidence that supports decision making that can be efficient. Let's define what are the best uses, the most efficient, and the most valuable uses for our resources. And today we're very focused on economic evaluations conducted alongside clinical trials. And so we'll talk a little bit more about how this is tremendously advantageous to be able to work alongside a clinical trial, given the sort of evidence that those studies provide, and how economic evaluation fits with that. So a little bit more on that. Obviously, randomized controlled trials are important because they generate evidence of the effectiveness of an intervention. And we need that for cost effectiveness. So just because something is effective, we like to then ask, is it also cost effective? So the ability to work alongside a clinical trial and plan for cost data collection, we can do very precise, what we call micro costing, to fill in half of the equation. And then in working with a randomized trial, we will have very strong evidence of effectiveness. The structure of a randomized trial allows us to directly compare two strategies, usually some experiment versus a control. We have advantages around minimizing bias and confounding, so some of the issues that we confront around selection bias. And if sufficiently powered, we also, the trial will reduce the likelihood of type 1 and type 2 errors around the measuring of effectiveness. So there's a lot of advantages for being able to work alongside, including the ability, as I said, to do detailed cost data collection. So we are focused on cost effectiveness analysis today, but just in case you're not aware, there's several approaches to doing what we call a full economic evaluation, and you can see them summarized in this table here. Everything begins with a cost analysis. That's really the foundation for any economic analysis, economic evaluation, but it's really how we measure and characterize the consequences, the effectiveness side, if you will, or the outcome side that varies across these different approaches. So with cost effectiveness, we're interested in one or two main effects that can be expressed in their natural units. So things like days of abstinence or time to relapse. These are common measures of effectiveness in substance use disorder research, and they work perfectly well for a cost effectiveness analysis. But we're also interested in quality adjusted life years. QALYs is one of the more common economic outcomes that we can use for doing what is technically a cost utility analysis, but we often refer to that also as cost effectiveness analysis. And then cost benefit analysis is different in that we translate outcomes into dollars. So we use price weights or monetary conversion factors to translate things like health services utilization or criminal activity, reductions in those things into dollars, and express those as economic benefits that can then be compared directly to costs. So there's a lot of studies that this probably won't be a surprise. A lot of studies say this is an economic study, an economic analysis, a cost effectiveness analysis, and they're not technically those things. So this is just kind of a heads up. You may be reading something that says it's a cost effectiveness analysis, and it's really not. We're going to explain in great detail what that means from our perspective. But I also want to mention something that is commonly misunderstood, which is something that's referred to as cost effective does not necessarily mean it's cheap. In fact, it usually does not mean it's cheap. And it does not necessarily mean it's cost saving. And in fact, in many cases, you can think about, we're investing in interventions. We do have to spend money, and there may not be a return on that investment for several years to come. And so that's just something important to keep in mind. This is especially relevant if you think about chronic disease interventions that require long-term care. You're going to be spending money over a long period of time, and substance use disorder is a perfect example of this, where many people have multiple episodes of treatment before they achieve a year of abstinence. And so we need to be thinking about long-term investment and long-term costs associated with treating substance use disorder. But it's also an important distinction for prevention interventions, right? So this is something where you invest up front in the hopes of, affecting things perhaps over the life course. And so again, this is a situation where the return on prevention could be far in the future and difficult to quantify in a cost effectiveness or cost benefit context. And so these are just some of the challenges that we wrestle with. The whole point of using cost effectiveness, as I said a couple of slides ago, is that it's going to provide additional evidence to help decision making. And so it really comes down to understanding how we value outcomes, the things that are being achieved through a particular intervention. And how do we value that is one way we think about that is our willingness to pay, or the stakeholders' willingness to pay. It depends on how you frame the, from whose perspective the analysis is framed. And Dr. Murphy will talk a little bit more about that. But these are the things we're thinking about. It's really an assessment of efficiency, but to do that, we need to think about willingness to pay and how we value these outcomes that we're capturing to express effectiveness. What it boils down to, it's fairly straightforward, actually, if you think about what we're calculating. So you're comparing typically two things, experiment versus control or intervention versus control, and essentially looking at the differences in cost divided by the differences in effects. And so that is the calculation of what we call the incremental cost effectiveness ratio. So you can think about it simply as dividing incremental cost, the additional cost in the intervention group relative to control, divided by incremental effectiveness. So the difference in effectiveness, presumably the higher cost intervention would also have higher effectiveness. And so how much greater is that effectiveness for the additional cost? That's really the question we're trying to answer. The cost effectiveness plane, economists love graphs and visual, figures. So this is one example of a visual support to thinking about cost effectiveness analysis. Most interventions would fall in quadrants 1 and 3, where you're comparing interventions that have higher cost and higher effectiveness. Quadrant 1, that's where most interventions would fall. In some cases, you may still be interested in looking at cost effectiveness if you're dealing with interventions that are relatively lower cost and lower effectiveness. They may be quite a bit less costly and not that much less effective. So it could still be the proper choice to, as far as defining an efficient option for investing in resources. With quadrant 2 and quadrant 4, this is a situation where obviously if the intervention you're assessing is much more effective and less costly, it's obviously going to dominate the alternative. So this would be the dominant situation. You wouldn't really need to do a full economic evaluation if you already see that something is lower cost and more effective. And in quadrant 4, this is where the intervention would be dominated. So obviously something that has higher cost and lower effectiveness would not be deemed an appropriate or efficient choice for resources. A couple of more sentences on willingness to pay. So this is, again, based on the perspective of the analysis, what is the stakeholder? And in some cases, that may be the societal perspective. What are we willing to pay for an outcome? And that's sort of the second question. Once you calculate cost effectiveness, you want to check in about, so is it cost effective? Well, what are we willing to pay? And so we're going to talk a lot about QALYs today, quality adjusted life years. You may already know this or you may not. So historically, we used to use, in terms of defining willingness to pay, the threshold for a quality adjusted life year was $50,000. Many researchers don't really know where this threshold came from. And if you were to translate that in today's dollars, I think this was from back in the 80s, it's somewhere above $100,000 per QALY. And so the recommendations today are that when you're doing a cost effectiveness analysis using QALYs, you use a willingness to pay of somewhere between $100,000 and $200,000 per QALY. And we'll talk about sensitivity analysis that's relevant to defining the willingness to pay thresholds in a little while. So this is where we get to interact with you a little bit. And some of you may already be very familiar with how to do cost effectiveness analysis. This is intended to be a little bit more of an advanced talk. But we'll launch poll 1 here and just take a look at these interventions and assume that, let's pretend that you're a member of your county's health commission. And you have a full budget to work with, $345,000. You have information here on what the cost of different interventions is and also the demand in the community for these interventions. So you look at that information, and then poll 1 is if you had to set the priorities for purchasing these interventions, without being subject to any kind of budget constraint, what would you rank first, just using the information that you see on the screen right now? So we'll go ahead and that poll is launched, so please feel free to make your selection. We'll just give it about 30 seconds. And I know we don't have a lot of time today to talk about what is your decision-making process on this, but I hope it illustrates, you know, some of the challenges that arise when you're trying to define priorities for funding these different things. Okay. So it looks like the winner is Smoking Cessation Campaign in High School, and you can see this is one that actually will touch more individuals. 12,000 individuals would be exposed to this type of, in this hypothetical example, to this preventive intervention. And so sometimes I hear that it's motivated by looking at the demand, how many people will be impacted. That helps determine the priority. But now if I were to add, let me see if this is going to work, this additional piece of information. So you have the cost side of things. What if you also had the outcome side of things, in this case, quality adjusted life years? So I'm curious how that might change. Actually, so we can launch poll 2. And actually poll 2 says, what if your budget was cut? So pausing on the outcome side for just a minute, if your budget was cut and you had to cut one or more of these interventions, which one would you cut first? So you have to cut about $100,000 from what you're spending, hypothetically. So which one would you cut first? Thank you, Mika, for controlling the polls. Or Sarah, I'm not sure who's doing it, but thank you. Okay, so the first one to be cut would be obesity prevention in elementary schools, that's very interesting because it's another preventive initiative, and before most people ranked the smoking cessation, you know, as one of the first ones to fund. So in the interest of time, this would be fun to discuss in more detail, but let's move on to poll 3. Now you have outcome information in terms of QALYs gained. And so now that you see that, which program would you rank? Does it change how you're ranking, the ranking you made in the first poll in terms of what you would fund first? Now really thinking about, you know, cost, thinking about value, cost per outcome. How are we able to maximize quality adjusted life years with these fixed resources? Okay, let's see. Yeah, so it's bounced around a little bit, but still smoking cessation seems to be the winner. Okay, great. So we can go ahead and close that. This is kind of a simple exercise, but it can illustrate how the challenges in trying to make decisions solely based on cost.
Actually, Catherine, needle exchange won.
Oh, it did? I didn't see it. Oh, okay. I didn't see that. Thank you. So that it did move around. Thank you, Bruce. All right. But anyway, this is to illustrate.
I always like advocating for needle exchange.
I know, me too. In Florida, we just have our pilot programs with that. So yeah, so it's interesting when it does change around. That's sort of the idea, is that when you have outcome information, it can change how you prioritize these funds. Okay, so we are going to take a breath. I'm going to stop sharing and turn it over to Dr. Sean Murphy for the second component to the presentation.
Great. We don't appear to have any questions in the chat yet, but just a reminder to the audience, please feel free to continue to send questions through the chat if you have any.
Great. Thank you, Catherine and Sarah and everyone else. This is very happy to be here. We're big fans of AHSR. As Sarah mentioned, we've been coming for a long time. So today I want to just build on what Catherine was talking about and discuss some of the methodological considerations that come into play when you're conducting an economic evaluation alongside a clinical trial. And then Dr. Jalali will take it from there and really discuss how you actually go about addressing those specific considerations. Okay, so first and foremost, the things that you need to consider when conducting an economic evaluation is, it's important to understand the specific disease or disorder that is being addressed. And so, a lot of people think that you just need an economist, right? Well, it's a little more, there's a little more to it than that. And you do really need, like I said, to have some understanding of what types of resources are generally used to treat this disease or disorder, medications, special diets, if they're required physical therapy, behavioral health care, etc. It's important to have an understanding of how long before you might expect to see an improvement. This is going to inform your analyses, of course, as well as healthcare resources, for example, and really other resources that are going to be frequently used by individuals if treatment is not successful, such as like ED visits, inpatient stays, etc., as well as things that we would expect to see a greater use in. In addition to that, you also really need to develop a good understanding of the intervention itself, as well as the study protocol. So, for example, is it a person or system level intervention? Who or what is being randomized? Is it, participant levels versus site level? What are the primary and secondary outcomes that are being addressed? What is the intervention period, as well as the follow-up period? And then at what points is the lead team really planning to interact with participants, and how? So for example, is it going to be self-report, let's say every 3 months, or something else, administrative data, or, et cetera. The final considerations, and this is a big one, which I'll discuss more in a second here, but what perspective would be most relevant? And when we talk about perspective, we're talking about the stakeholders that Catherine referred to. So remember, the intent of an economic evaluation is to inform real world decisions, right? Well, whose decisions are you trying to inform? And that's really what we're getting at here. If you look at the Newman et al. Textbook, which is the second panel on cost effectiveness in health and medicine, and really kind of what I'd say the overall guide for doing this type of work, they recommend 2 reference cases: the healthcare sector and societal, and I'll come back to those in just a second, as well as anything else that is especially relevant to the study that's being conducted, which is what I'm referring to when I say primary. And the reason being for the healthcare sector and societal, really to increase comparability among studies, or between studies rather. Finally, outcomes are, and we'll talk about those in a minute, data availability, and then rule of reason, meaning, what level do you really need to dig down to, right? Because oftentimes getting down to the exact level, the exact detail of what a specific healthcare resource costs can be very time consuming, and in the end merely may not be that beneficial. So there's that consideration as well. As far as perspectives, like I said, this is really the first thing I would say that you need to establish when you're conducting an economic evaluation. This is a list, as Sarah mentioned, you'll have the slides, so you can always come back to this, and so I'm not going to go through each one, but it gives you an idea of just some of the different perspectives that could be adopted. It's not all of them, mind you, but a fair number of the most popular ones. The next thing, or another thing, is deciding what your price weights are going to be and how you're going to value your resources. So as the first bullet mentions, especially alongside clinical trials, and especially in the US, where we tend not to have as many fully integrated health systems, or we don't have a national health service, it's very difficult to capture resource utilization comprehensively, right? So often we end up relying on self-report. And when it comes to actually valuing resources, what we do usually is we use a resource costing method. So our first concern is really with gathering all of the resources that we want to keep track of. And then secondarily is the valuing process. And what that entails is determining a price weight for each type of resource unit and then multiplying it by the units of service, of course. So the important thing to remember about price weights, though, is that it's going to depend on your perspective, right? So you want it to be reflective, I guess you could say, of real world costs that that particular stakeholder is going to face. So if we're talking about societal or healthcare sector, the weights should really reflect the opportunity cost of the resources to society / the healthcare sector, meaning we want to capture the actual value of those resources without accounting for other things that tend to be built into a price, typically like risk, profit, etc. We just want the value of those resources. Versus, let's say, a third-party payer perspective. So let's say a healthcare insurer. Well, of course, if we're conducting the evaluation from that perspective, we would want those price weights to reflect the actual payments that they have to make. So Medicaid, for example, what do they actually pay for an ED visit? Okay, as far as measuring effectiveness, as I mentioned before, we need to understand the objective of the program, and we need to understand our stakeholders and decision makers. So questions we should ask ourselves, for example, is the measure that we're looking at generalizable enough to inform their resource allocation decisions? And do we have enough information about the measure to determine whether the cost of increasing it is a good value? And we'll come back to that in a second as well. So clinical measures are great in many ways, right? So one that Catherine mentioned earlier was time abstinent. Let's say time abstinent from opioids, right? It's kind of it's a good measure of the success, so let's say, of an intervention for substance use disorder. It's a proxy for treatment adherence, oftentimes for pharmacotherapy, et cetera. So it's clinically meaningful, right? And the interpretation is fairly straightforward. So a cost per week of abstinence from opioids, or cost per however you want to operationalize that. The deficiencies is that it only allows for value comparisons among studies using similar outcomes. So when you look at your cost per week of abstinence, let's say, you're only going to be able to compare that to other substance use disorder studies. You're not going to be able to compare it across different diseases and disorders, which is, of course, something that you really want to be able to do if you're making decisions at a higher level. And the other problem with the other problem with clinical measures of effectiveness is that you don't have a generally accepted value threshold. So it's not as easy to say this is or is not cost effective. So this really brings us to why we also typically incorporate quality of life. So Catherine talked about qualities, and that's what we're referring to here. There's a couple of reasons. Really, quantity of life, when you think about it, is only one aspect of health, right? Or any other clinical measure, let's say. Whereas when we start talking about health-related quality of life, it's increasingly recognized as a key indicator of patient well-being, and it's not captured in clinical measures typically. So for our primary economic effectiveness outcome, we use what is called the quality adjusted life year. I think most people on this call are probably familiar. It has a broad economic interpretation. So the idea being a quality is a quality is a quality is how the saying goes. But the point being, cost per quality adjusted life year can be compared across diseases, disorders, interventions, you name it, theoretically, of course. So how we capture that is we weight the duration of the time spent in a given health state by the health-related quality of life or utility weight that's associated with that health state. So we will give, let's say, a generic health-related quality of life instrument to the participants at each measurement point, right? And then the assumption essentially is that however that's scored is going to define that your current health state. And essentially the idea being you stay in that health state until the next time is captured. And we continue to do that with the intent being to capture these curves essentially. Right, so you can see, here's an example from the Whitehead text. So this would be obviously the group who receives treatment, and these would be average points that were measured using the instruments. And this would be the group without treatment. So what we're really interested in are the area underneath these curves, and more specifically, the area between these two curves. So that's what's going to give us our quality adjusted life years gained from treatment. It's another important consideration, just quickly, when you're actually doing your analyses, of course, is to make sure that you adjust all of your price weights for inflation. So make sure you're measuring everything in the same year's dollars, right? Apples to apples and all that good stuff. And then whether or not you need to adjust for time preference, right? Remember, keep in mind, these are two separate issues. So time preference, the general rule of thumb is that we don't need to make an adjustment if the measurements are within 12 months of baseline, but anything past that needs to be adjusted for time preference, just meaning, for example, that let's say $100 a year from now is not worth the same to us as $100 today, even after you adjust for purchasing power, right? You would rather have it today than tomorrow. Okay, so Catherine discussed the incremental cost effectiveness ratio, and I'm going to discuss just a few more specific points on that. And the big one being that when we're looking at the difference in cost and effectiveness, what's really important is that we are looking at the arithmetic means, right? So a couple reasons for that. One, it's an important summary statistic, right? So it's going to allow us to most easily determine total cost and effect when we're looking at an intervention. And of course, you just take the mean times the number of patients or participants. That's going to give us our total cost or our total effect, right? The other reason, the more theoretical reason, is that it allows us to better assess Kaldor-Hicks social efficiency, which essentially says, it's telling us whether those who are better off as a result of the intervention compensate those who are made worse off, such that everyone is at least as well off as they were before. Okay, so we've established that the arithmetic mean is very important, right? Well, we also know that when we're talking about, let's say, costs, for example, that they tend not to be normally distributed, right? Which is the reason that a lot of people say, well, why wouldn't we look at the median? Well, as I mentioned before, we've got good reasons for that. So then how do we get an accurate assessment of the mean? Okay, well, we know, like I said, that these data tend to violate assumptions required for parametric statistical tests. So for example, as hopefully everyone knows, OLS assumes that residuals are normally distributed. And as I just mentioned, that tends not to be the case for especially, let's say, cost data. And so if we use a regression that assumes an incorrect distribution, so if we use a normal, an OLS when our data actually look something like these two screenshots, then we're going to end up with biased estimates. Okay, and so Dr. Jalali will walk us through how to deal with that. Okay, another piece that I want to draw attention to is just the measuring and valuing the intervention costs themselves. So this tends to be a very important and often not as highly valued as it should be component of the economic analysis. But regardless, it's very important that we go in and we get an understanding of what resources as well as costs are required to both implement and sustain an intervention. And how we typically do this is with a combination of what we call macro and micro costing techniques. So macro costing is what's referred to as like a top-down approach. And essentially you're allocating a total budget to specific services such as hospital stays or doctor's visits, and usually would be based on financial information, let's say, obtained from the different sites. Whereas microcosting is referred to as more of a bottom-up approach. And what we're doing there is we're doing a detailed analysis of the changes in resource use due to a particular intervention. So this is where we really get into the weeds, and we typically obtain this information via semi-structured interviews with site leaders and other relevant staff at a clinic or hospital, wherever our intervention is taking place. And we usually use kind of some standard data collection tools, costing tools such as the SASCAP or the DACAP to really help us inform those interviews. So we don't follow them line by line necessarily, but those are great resources, to ensure that you're capturing all of the relevant things that you need to capture. So as far as intervention costs to consider, how we tend to structure these when we're doing an analysis of, like I said, a costing analysis of the intervention is really in three groups: the startup costs, the time-dependent costs, and your variable costs. So your startup costs are going to be your fixed costs, right? These are going to be things that are required really just for startup, and then over time they're going to become negligible, but obviously still something that's very important for individuals or clinics who are interested in incorporating this type of intervention, right? They need to understand not only what's it going to cost once we get things rolling and everything kind of settles out, but what's it going to cost to get this started. Time-dependent costs are costs that are going to vary with time rather than the quantity of output. So let's say this is a cost that you're going to incur every month over this time period of interest, whether you have patients or participants or not, right? So a good example of this, of course, would be rent or a lease for equipment. And then your variable costs, as hopefully everyone remembers from at least intro to Econ, is that these are your costs that are going to vary with output. So the more people you're treating, for example, the more of these things that you're going to need at certain points, whether that's staff, whether that's supplies, you name it. And the final consideration that when conducting a microcosting or macrocosting analysis is those opportunity costs, right? And what I mean by that are costs that may have been subsidized or provided for free, even for certain, in certain instances. It's very important that we still provide a value for those, because that's not always going to be the case, right? Just because these people were willing to donate their time in this particular setting does not necessarily mean that that's going to be the case when you go to start this up somewhere else, right? Missing data is another big consideration, especially when we're talking about doing evaluations alongside clinical trials. And this is something that is very much of importance for us, not just the biostatisticians. So thing we really need to do is we need to distinguish between item non-response and missing or censored. So we account for that item non-response as much as possible. So a good example of that might be, do they answer, let's say they answered no to having particular utilization of, let's say, ED visits and things like that, but at the same time, they may have answered yes to something else, and we're able to kind of infer from that they did have, let's say, some outpatient visits or something like that. That's not a very clear example, but the point is oftentimes from their responses, you can infer whether or not it was actually missing. One of the things that we do to help with this is when we ask questions about self-report, et cetera, we use a time anchoring, meaning we'll say, well, okay, how many ED visits did you have since the last time you filled out this survey, right? And so even if they skip a time point, they show up for visit 1 and visit 3, but they miss visit 2, we're able to kind of backfill that in. And so it's not actually missing data, right? Now, when we're left with the data that actually are missing or censored, first thing we do is determine the mechanism of censoring. So is it missing completely at random? Is it missing at random or missing not at random? Those are the big ones, of course. If it's missing completely at random, list-wise deletion is fine. Theoretically, it will not lead to bias, although best practices still recommend that you still control and try to keep those data, control for the missing data. If it's a missing at random assumption, and statistical techniques will sufficiently control for bias, and Dr. Jalali will talk about some of those, such as multiple mutation. And then missing not at random, really that's the toughest one to deal with. And essentially what it comes down to is conducting sensitivity analyses to assess the potential impact on the estimates. And the tricky part is that you can't really, it's not easy to determine whether or not you have missing at random or missing not at random, right? So in reality, you should just do the sensitivity analyses no matter what. Oops. Okay, so the final part that I'll discuss is just the uncertainty. Of course, with any analysis that you do, and economic analysis, of course, is no exception, is to develop a better understanding of where your uncertainty lies. So uncertainty in the assessment of costs and effectiveness. Will the expected costs and effects be the same in a real world application? Of course, is what we're really trying to get an idea of. How robust are our findings? So we need to account for potential sample selection bias the best we can, natural variability in patients' outcomes / costs due to unobservable characteristics, as well as the quality and relevance of testing inputs or other model parameters. And in the end, all of this is going to lead us to not only just assessing how robust our findings are, but additionally, like how confident we can be in whether or not something would be cost effective at a given willingness to pay value, which is something Dr. Jalali will also get into. So that is all I have. I'll stop screen sharing so that Dr. Jalali can share his, but I think we have time for questions. If anybody has any questions while we're kind of getting up and running.
If you have a question, please feel free to put it in the chat, or you can unmute yourself and ask it verbally.
Was there any questions? Should I start? Okay, well, hello everyone. Am I not muted? Hold on.
You sound great.
Oh, I'm okay. I didn't get any response, so I thought I was muted. Perfect. Let me start that over again. So, well, thanks for sticking around to my part 3. This section is titled GLM Modeling for Economic Evaluations using Stata. So the GLM, which stands for Generalized Linear Models, is the workhorse statistical model for studying participant-level healthcare data and economic evaluations alongside or parallel to clinical trials. For example, a variable in this kinds of studies would be longitudinal health service expenditures or health-related quality of life, as was mentioned before. Now, myself as a postdoc and early career researcher, I often find that there exists a barrier when you read a statistical paper talking about a method and then actually applying it to studying a data set. And so the purpose of this section is to provide some familiarity with some of the main statistical procedures that are recommended and employed by studies in this field, with example code that hopefully kickstarts your application of these statistical tests to your data set. Now, Stata is the most popular programming language among economists, but you can easily translate the code in this section to your preferred programming language, since the slides will be shared. And so the main part here is that the main difficulty is sort of determining the best variance and link function of a GLM model, as was discussed by Dr. Murphy. So I'm going to illustrate the step-by-step process and doing that. I will present mainly 4 of the main statistical tests that are commonly used to determine GLM family and link function. I will provide a discussion and code for how to run recycled prediction methods for estimating the adjusted arithmetic means of your outcome variable. And then I will conclude with the discussion of how to estimate bootstrap standard errors and to determine a distribution of your ICERs to account for uncertainty. And at the end, if there's time, I will display some sample cost effectiveness results and the cost effectiveness acceptability curve and how they look like from a recent trial that we are doing. Okay. So first, let's take poll number 4, which will ask for you to describe your level of experience with using a statistical software programming language to do your research. Because if it turns out 100% have advanced knowledge, then maybe I can just cut this talk short, but let's see what the distribution looks like. Wow, okay, so a lot of folks, about half, have advanced knowledge or experience, but there are about a fifth people with very basic knowledge and no experience. So, okay, that's good. So a lot of this code probably will be elementary for some folks, but we will assume that the audience here is around basic or to intermediate level. Okay, so in order to discuss the GLM model, it's important to recall some of the basic assumptions of the OLS regression that was mentioned by Dr. Murphy for studying a dependent or response variable y. First, there is the assumption that your variable y is a continuous variable and that it's characterized by a normal or Gaussian distribution. And what that means is that your y can take any real number from negative infinity to infinity, that the mean and median of that distribution should be approximately equal to each other, and that there's going to be zero skew. And what that means is that the distribution is going to be symmetric on the right side of the mean and on the left side. So they're going to look very similar. And also the relationship in the OLS regression, the relationship between your independent variables, your covariates, and the response variable y is assumed to be direct and linear. And in addition to that, the variance of the distribution of a normal Gaussian distribution is assumed to be constant and not related to the mean of the distribution, which means that if you move the mean of the normally distributed data set around, the distribution is going to still look the same, where that's not the case for the exponential family. So what the GLM does is it's just a generalization of the OLS regression to allow for fitting a broad set of distributions, mainly from the exponential family, for your response variable y. And it allows you to include a flexible relationship between the linear predictors, your covariates, and the expected value of y, which should be equal to your mean. So there are two main components of the GLM. The first is your family specification. And this is where you specify the distribution that reflects the mean variance relationship of your response variable. And so the question you're really trying to ask here is the variance of my variable of y going to be a function of its mean, and how are they related? And as was mentioned, the Gaussian or normal, there is no relationship. However, in the exponential families like Poisson, gamma, and inverse Gaussian, there is a functional relationship between the expected value of y and the variance of y. So for Poisson, the variance is proportional to the mean. It's a basic result in statistics. In gamma, the variance is proportional to the square of the mean, and in the inverse Gaussian, the variance is proportional to the cube of the mean. The other component is the link function, and this essentially specifies a functional relationship, which we denote by G, between the expected value of the response variable to the linear predictors, right? And here we describe, G of the expected value of y is equal to the linear predictor. But in these cases, especially for the GLM, what it actually employs is the inverse of that function. So whatever this link function is, it has to be invertible. And an example here is below where we use, say, log as our link function. And the inverse of that would just be the exponential of the predictors, of the linear predictor. And you can note here that GLM is a generalization. So the OLS assumes that this link function is just an identity function. So 1 times the linear predictor. So let's, since we're going to be using stata code here, let's first review the syntax for running a GLM, which is the main statistical model in this data. And stata is kind of a functional oriented programming language. You start with a command which tells it to do something to some data set. The GLM is the command in stata to run a GLM regression. And of course, you include your response variable y and your set of covariates x. And it also allows you to include probability weights by the p-weight option. This is becomes useful when you're trying to address missing data using inverse probability weights. You can cluster your standard errors by participant or provider. And then the most important part here is that in the options after comma, the GLM, you would indicate what family and link function you want to use. If you don't include anything, it will just assumes it's Gaussian with the identity link. And if you only include a family, let's say family Poisson, it has a default link that's included. But if you want to vary the family and link, you have to specify both of them. Now, we won't discuss it here too much, but in some applications of GLM to healthcare data, where you have semi-continuous data, where you have a lot of zeros or excess zeros, and that you may want to employ a two-part statistical model, you can also fit two-part models in GLM, and that syntax there sort of tells you, you can indicate what you want the GLM to be for the first part, which is whether it's zero or an observed cost or outcome. And in the second there. So that's the syntax there, but we won't discuss this kind of model today. Some common GLM families and links. The common families are, of course, Gaussian, Poisson, Gamma, and inverse Gaussian. You can also include power, which is essentially is a sort of a superset of these. Now, of course, we recall that the variance function for Gaussian is not related to the mean, while it is a functionally related for the other common families. And as I mentioned, the power function encompasses these families as well. Common links that are used is the identity, which is what is assumed in the OLS regression. Here I include both the G and the inverse. The power link is a very flexible one. And log for both Poisson and Gamma, log is the default link that's used. And it's important to note here that when you do the power link to the power 0, it assumes that it's log. And so when I tune GLM models, I just look at different power links and include the 0 in there for, let's say, if I'm looking at a Poisson family. And of course, reciprocal is another one. Now, to sort of find the most appropriate variance and link functions of your GLM model, so that you can estimate the multivariate adjusted arithmetic means that are not biased. It's a bit of a time-consuming iterative process where you start off with a model that a priori you think is going to fit the data well after you look at the distribution. And then you run a statistical test to see if that family that you have chosen, given a particular link function, is going to be the best, most appropriate one that describes the relationship between the expected values of the response variable and the variance of the response variable. And then you would, once you determine a more appropriate or a better family, you can then test to see if your original link function that you've included is optimal. And if you find that it's not, and that you determine a different link function, you want to go back and check if for that given link function, does your family distribution correct, and on until you end up with some optimal model. So this could sometimes be time consuming and sometimes it could be quite short. So it varies. Now, why do we want to determine the best sort of family distribution? Dr. Murphy mentioned that you can have biased or inefficient estimates. You don't have to worry about the code here. This is just simply demonstrating that if I were to run a regression where I know the relationship between your covariate X and Y is 1.5, if I change the variance or your error term to follow a certain distribution, you can see that that coefficient becomes a little bit more accurate if you have the correct family. Okay. So first, as I mentioned in that diagram, we first want to determine the best and most appropriate family. And the modified park test is what is recommended and most employed in this literature. So we want to identify, remember the original idea is we want to identify if there's a relationship between your expected value response variable and the variance of the response variable. And we noted that the Gaussian is constant, so there shouldn't be a relationship. But in the exponential families, the variance is going to be a function of the mean. So here we have variance of y is equal to a of theta, which is some scaling parameter, times some functional relationship between the expected value of y and the variance. So for example, if y is distributed by gamma family, then the variance is going to be proportional to mu squared. And so your variance should look something like this, where it is equal to some scale parameter theta times mu squared. So in order to test the above relationship, there are two approaches to the modified Park test. The first one is a preferred approach. I include the second one there, and I'll show the code for the second, but because in Stata, the GLMs are fit using a maximum likelihood procedure. And sometimes numerically, Stata may not be able to estimate that function. So if it fails, then there's a second approach to use, which is not as efficient, which will, because it's just regular OLS, it will definitely fit the model. So the main approach is that you want to, given your chosen GLM model, you run a gamma regression of the square of the residuals in raw scale. And by raw scale, I mean whatever the response variable was. If your response variable is dollars, you want it to be back into dollars. Because if you run a GLM with Poisson or gamma, you don't get, you have sort of like log odds in logit, etc. So that there, y minus the fitted y squared, that's your residuals, your variance. And you run that regression on the log of the expected value of the response variables, log of expected value of y from your original GLM model. And then you run a hypothesis test of the coefficient in front of the log and test to see if that coefficient equals 0, 1, 2, and 3. So then you can discern that functional relationship, whether if it's in the Poisson, if it's exactly equal to 1, or if it's related to the square of the expected value. And again, if that doesn't work, then you can run an OLS regression of the log of the square residuals above. So those residuals, but you log them in this raw scale on the linear predictor XB and run the same statistical test. And as mentioned, if the test of that beta is 0, it's telling you that there is no relationship between the variance of y and the expected value of y. So that gives you evidence that that it's probably Gaussian distribution or normal distribution. If that beta, you find statistical evidence that it's equal to 1, then that's evidence that it's the Poisson family fits it well. If it's equal to 2, it's gamma. If it's equal to 3, it's inverse Gaussian. Let me correct myself. It's not that you test for equal to 1. It's sort of you reject the other null hypothesis. So you want to test all of these. And then the one that you don't reject is what you will use as evidence for. So this modified Park test statistic will provide evidence for which of these families is most appropriate for the GLM. However, there is an assumption here is that this test assumes that whatever link function you used is correctly specified. So it only gives you evidence for that particular family given a certain link function. Now here's its data code for approach 1 and 2. And in the first line, you start off with your model, GLM, Y, X, whatever family and link function you use. And then you use Stata's predict and generate command to first predict the expected value, and to get the expected value in ROS you put the MU command option after comma. Then you can generate the log of that expected value. You can then predict the residual and then take the residual square. And then you would run the test. Right here, it indicates the modified Park test, which is you run a regression, gamma regression of the residual squared on the log of the expected value. And then you can run a coefficient test for whether that coefficient is equal to 0, 1, or 3. And then the alternative version is below, similar process, but you're predicting a different, you have a log prediction of the residual squared on the linear fit XB. Okay. So as I mentioned, the modified Park test provides evidence for what should be your suggested family, assuming a given link. So now you want to test if that assumption is correct. So how do we test this assumption? This one is a little bit more tricky because there are sort of 3 statistical tests that are often used in conjunction with each other. One is the Pearson correlation test. The second is the Pregobon link test. And then the last one is a modified Holmes-Miller-Lemshow test, which are probably familiar with the last one as it applies to logit regressions. Now, each of the above tests provide evidence for or against a chosen link. So this is where the time-consuming process comes in, where you want to run this test on multiple variants of your link function. The Pearson correlation is probably the easiest and most informative. And here we're simply just going to examine the correlation between your expected values of y and the residuals of the GLN model and raw scale. And so this is just simply is a statistical test for any bias in this expected value. And so again, you start with, in Stata, you start with your original GLN model, you predict the expected value, and then you predict the residuals, and then run PW core and look for the significance, and then include the SIG option, which will give you the p-value there. So in this case, you want to make sure that you don't have your p-value is greater than 0.05 or whatever your significance level is, so that it will provide evidence whether there is any kind of systematic bias in the expected value of y given your given xb. This Pregobond link test, which is sort of similar to an older Ramsey reset test. Now, this is just a statistical test to check for linearity between the response variable y and the linear predictor. And what it would give you is evidence that either the link is misspecified or that your covariates are missing some nonlinear combination. And so what we want to do here is we want to regress your y, your response variable, on your linear predictor and the square of that linear predictor. So we start with your original model. You predict the linear predictor with the option XB. And actually, that's third line should be gen, not predict. I apologize. And then you generate the square of that predictor, and then run the same GLM model that you used with the same family and link on the linear predictor and the linear predictor square. And that second one is sort of the non-linear term. And then you look for the statistical significance of that nonlinear term. And so if it's less than your statistical significance level, then there's evidence that your link function is not correctly specified. Now, one problem with the Pregobond link is that we're looking at only a second degree nonlinearity. So what if the nonlinearity in that model that you used is follow some higher order polynomial? So here's that little squiggly line. Now it's difficult to run a bunch of tests where we write, regress on xb squared, xb cubed, or xb squared times xb cubed. That's going to be quite cumbersome. So one solution is use the modified Holmes-Miller-Lemshow test, which tests for a systematic bias of your predicted response and residuals across different percentiles of your predicted data. And that can be in Stata, there's a command called xtile, which allows you to run this test. And what we do is you again now all these tests, you start with your current iterative model. You start with that, you predict the residuals, and then you predict your linear predictor, your linear fit. And then using xtiles, you can generate a variable based on that linear predictor xb, and then you can give it the number of quantiles, and it's standard here to use 10, so you put n quantiles 10. And what it would do is that it would take those predictors and it would create a variable, and it says 1 through 10 for whatever corresponding to whatever percentile it is, or in this case, decile. And then you take those that variable and you turn it into constants. So 0 if it's not in the first decile, 1 if it is, and you have another variable, 0 if it's not in the 20th decile, 1 if it is, etc., all the way to 10. And then you run a regression of your residuals on all 10 of those dummy variables, indicating what decile the linear predictor fit in. You want to make sure to put the no constant option there because we want to look at the constant levels across all 10 and make sure to include the robust here because we're testing this because we know that the variance is not homoscedastic. And when you do that regression, what you get is this table to the right, which shows you the coefficients. And you can see that this linear predictor starts out in the lower decile to sort of under to be negative and then goes positive, sort of follows this non-linear pattern. And then you will run a test, XB, and you list all those variables, which runs an F statistic on the joint statistical significance of these. And that's where the modified Holzmeier-Lemshow test is. And display here, RP will give you the test statistic. You can see here that we failed this test. So whatever link we used is failed this statistical test. So we might want to adjust our link function. Now, those three, I said we have to use them in conjunction. So how do we choose the most appropriate link function using these three statistics? And this is where I think econometrics becomes an art. So the main necessary condition is you want to choose the link function such that all three test statistics you find no evidence that there's any kind of bias in all three test statistics. So you want to have p-values greater than whatever your significance level is. Now, what problem becomes is that there may be more than one link function that meets all the above criteria. And this happens a lot because as I mentioned earlier, the more flexible link is the power link. And so you might find that power links between -0.5 and -0.1, or maybe even out to the log, all meet this test. So how do I know which one is the best? Some I've seen suggested that they would take sort of the average of the p-values, etc. Or you may want to prioritize certain tests over others. So the modified Holzmeier-Lemshow test doesn't assume what kind of non-linearity exists in the data set. So that may be more important than the Pregobon link test. One simple approach that I'm suggesting here is to choose the link that maximizes the p-value from the Pearson correlation test because that tests its impact on the expected value of y, subject that you have non-significant results across the other two tests. And so that could be one simple approach. I don't think there is an established procedure of how to weigh these three, but this is one approach that I would suggest now that one can use. Although one problem with this approach is that you may have a problem of overfitting, but that's a different topic. Now, as is mentioned, the method of getting the adjusted arithmetic means controlling for the average of all populations is using the recycle predictions. And the problem here is that the coefficients from the model, so once you find the most appropriate GLM model, the coefficients in that model is an estimate of the marginal effect. So 1 unit increase, how does that impact the outcome? But we want this covariate adjusted arithmetic means. And to derive this value from your GLM, we will use a method of recycle predictions, or sometimes called predictive margins. Now, there are two approaches to this. There's sort of a longer step-by-step approach where you create some temporary treatment variable and you run a regression and you replace that treatment variable with 0, assuming everyone is in one group. And then you predict the outcome for the whole population of your study if everyone was in the control, and then do the same thing for treatment. And that could be a little bit long, and then you summarize it. But in Stata, it's really nice because it has the margins command, which will do this automatically for you without needing to generate new variables. So after you run your GLM model, here we have GLM, your response variable Y, your treatment indicator, your covariates. After you run that, you can simply say margins. And within the margins, you can indicate that you want to run this at treatment equals 0 and 1. And there it will provide with the recycle predictions. So here for the treatment group, which says 1, which Stata will actually indicate the group 1 is equal to treatment equals 0 or something. You see it's 0.788, and number 2 is 0.80. Now, one of the reasons I like this approach is because when we are calculating qualities, and we saw that earlier graph about the area under the curve method, it could be cumbersome to sort of collect all these, and you may make errors if you were to calculate it with a calculator. So, and also you want to have the treatment effect at different time points. And so what I like in Stata is to make use of their binary operator, which has 2 hashtags. And what this does is to take all the allowable combinations of a variable, like a treatment variable, and the time points. For example, if your outcome is health related quality of Y, I will put Y times treat using the binary operator for factor combinations with my time variable week and then my other covariates. And then when I apply the margins, I can actually tell the Stata I want to do the margins for the different points of time, weeks, at treatment equals 0 and 1. And you can see on the right, that is what the output becomes. I have for treatment group 1, what is the predicted outcome at time 0? Treatment group 1, what is the predicted outcome at weeks 12 and weeks 24? Same for the treatment group 2. And then once I have this, especially when we're trying to find a distribution and run Bootstrap, I can use the matrix command to save those results, which will save a 1/6 matrix or vector, and we give it a name. We call it HRQL. And so what Stata uses is that if I can use HRQL 1, 2, that is equivalent to column 1, row 2, which is 0.7933, which is a value at week 12 for treatment group 1. And again, as mentioned, this helps us in terms of the area under the curve method, and this is what Dr. Murphy discussed. So we essentially want to find those points where the variable change to discrete points and calculate the difference. And so given that we saved that result, we can apply the area under the curve method using Stata, using their scalar option, which just simply says, let's define a number. And I define the first one, the qualities for 24 weeks of the control group. And then here you can see in those lines, I can take different components of that vector that I saved and calculate the cost, the quality adjusted life years by multiplying the value of the health-related quality of life and the time spent in that state. And here you can display quality control and quality treatment, and it will automatically calculate that for you, especially if you're running bootstraps and you want to find 1,000 of these variables. It's really helpful with the margins command to do that. Let me just check the time. Okay. Now, addressing missingness, there are 2 main common methods to address missingness. One is the inverse probability weighting, which I mentioned the p-weights option in GLM allows you to do that. And this method simply applies weights to subjects in your data set to account for underrepresented subjects. You can think of it as more of a rebalancing, and it's really helpful for attrition in your data set. And the other approach is the multiple imputation approach, which you substitute multiple plausible values for missing observations based on the observed data, and you would run multiple regressions and you appropriately combine them for an overall effect. Now, I won't go into code with these because there's a lot of resources online for addressing this problem compared to how to address GLM model specifications. So that, for the sake of time, I will skip. The more important thing here for economic evaluations is to account for uncertainty in your, let's say, distribution of the AHSR. using the bootstrap method. A quick review of bootstrapping, you essentially have your original participant data. And what you do is you sort of do a random sampling with replacements to estimate the distribution of a particular statistic. It could be the mean of quality per treatment group. And so you do this process where you randomly resample for, let's say, 1,000 times. You run the GLM model, you derive your outcomes, and you calculate your qualities. You do it 1,000 times, and then you would end up with some distribution for your quality-adjusted life years or for your cost by a treatment group. And to do that in Stata, there's two approaches. It seems like there's two approaches to everything. The first one is a really efficient approach. However, it's a more advanced approach, and that is to write your own R class or E class Stata program, and then running Stata's bootstrap command. Some of you who said you're advanced probably know this. For some of those who are not advanced, it's maybe more helpful to do it step by step, following the kind of the figure that was provided before. And you can do that in Stata as well using the bsample command. And what the bsample command does is that Stata will conduct a resampling and generate a new data set based on your current data set. And then you can have it run your GLM model and then store your predicted, recycled predicted values. I won't go into too much detail of these lines. This is not fully complete because you'll need to write a way of collecting those and storing those results for each 1,000 times. This is simply just the bare bones. But I want to mention a couple of options. One here, the capture noisily option is important because, as I mentioned, the GLM runs the model based on maximum likelihood, and sometimes it is not estimable, so you'll have an error. The capture noisily option tells Stata, if there's an error, just move on, don't stop. It's important in the bsample, there are two important options that to be considered. First one is that you want to stratify the sampling by treatment, because you want to be able to identify the treatment effects. So if it could be possible that it randomly samples too much control and not enough of the treatment group. And second, since we're looking at longitudinal data, you want to sample participants and not just observations, right? Because we want to capture the longitudinal effect of treatment and control. So here, where the cluster command here, you just simply include your participant ID or your patient identification variable. Here, it's important because we run the GLM, as I mentioned, it may not converge or may not be estimable. For you to collect both whether the GLM model had converged, which means that it was able to find a solution to the log likelihood function. And that can be easily pulled by using the E parentheses converged underscore GLM. And then when you run your margins, you can then again store using the matrix command the outcomes of the data. And so you would collect each bootstrap statistic for treatment and control, and then calculate your incremental cost and effects, and use those to present sort of a distribution. So after you collect the bootstrap estimates, you can calculate the bootstrap standard errors of the incremental cost and effects of treatment. You can calculate the percentile confidence interval of the incremental cost and effects using those bootstrap standard errors. You can plot the results of these on the cost effectiveness plane. And once you plot the cost effectiveness plane, you can analyze that distribution and calculate or present a cost effectiveness acceptability curve, or CAC.
Dr. Jalali, we only have about a minute or two before we need to shift to announcements, if you could be moving to conclude.
Perfect. So I have two slides, and it's simply, here's what a sample results of that cost effectiveness plane will look like. And here's sort of a sample result of the acceptability curve, where at the bottom, we have your particular willingness to pay threshold, and then you can find what proportion of that distribution was cost effective given that willingness to pay. Okay, perfect timing. Thank you. maybe a minute for a question, or we can do the announcements if there wasn't, although there wasn't many questions earlier. So thank you very much.
Wonderful, thank you. And I want to thank the speakers for generously offering to share these slides because they are full with such practical and useful code. So thank you all. If maybe we could put back up your emails. We can take a question verbally if anyone has, but also the speakers have also offered that you're welcome to email them questions, or if you put questions in the chat and we don't get to them now, they're happy to take those questions compiled from the chat and we can email them out when we announce that the slides are up. Does anyone have any questions before we proceed to announcements? It was very detailed and straightforward, so perhaps it was so thorough that no one has questions, but does anyone have questions?
I have a question. Is everyone ready to go and execute that command, those commands?
You did get a comment that it was a great review of GLM, so congrats on that. Yeah, I'm rusty, but I feel ready to try. All right, great, thank you. And if we could stop share, I do have two just final announcements I'm excited to share with the group.
Oops. There it is.
Okay. All right, so I have two quick announcements. The first is we'd like to announce that we have another monthly workshop scheduled for February. It is led by our friends and colleagues at the Brandeis Harvard NIDA Center to improve system performance of substance use disorder treatment. It's a very popular workshop specifically for early investigators on tips for how to launch a successful career, and it will be comprised of a diverse panel of mentees and mentors. We've had this panel in the past at other AHSRs, and it's been requested by popular demand. So we look forward to hosting that again and hope you can all mark your calendars. And then I also want to make an exciting announcement that leadership of AHSR 2021 has been confirmed. AHSR 2021 will be led by a team based at the Brandeis Institute for Behavioral Health. Some I guess good news and bad news is we have a host, which is very exciting. I think the tough news is that this is a climate where it's very difficult to commit to in-person programming for hotel contracting and other big logistics. So the AHSR National Committee has made the decision to have AHSR 2021 virtually, and then we will convene in person in 2022 in Palo Alto. So please mark your calendars for that as well. We cannot wait to get together with you all in person in California in a couple years, and we're very grateful to the team at Brandeis for leading next year's AHSR. So please stay tuned to your emails. You will get a post-event evaluation, and we greatly appreciate your feedback as that is something we report to our funders, and it helps us improve our programming. So thank you all so much for joining today. We really appreciate you, and thanks again to our friends at Cherish.
Bye. Thank you.